Welcome to the NFP Podcast, where we explore the empowering world of natural family planning. I'm Amy Smith. Join me and my co-host Emily Appledorn each week. Together, we're here to dive deep into the science, the stories, and the spirituality behind NFP. Every week, we push back against the free love culture and advocate for a culture of responsible love, where intentionality and respect are at the forefront of family planning. Join us as we discuss everything from the practicalities of charting and fertility awareness to the profound impact NFP can have on relationships and communities. Whether you're new to NFP or a seasoned pro, our podcast is your go-to resource for honest conversations, expert insights, and real-life experiences. So grab a friend, settle in, and get ready to be inspired. This is the NFP Podcast.
Dr. Teresa Hilgers is an OBGYN at the St. Paul VI Institute. She was born and raised in Omaha, Nebraska, and left there to go to Baylor University in Waco, Texas for her undergraduate degree. After that, she ventured to Washington, D.C. and received her master's degree from Georgetown University, before returning to Omaha, where she completed her medical degree at Creighton University. For her residency training, she went to Mercy Hospital in St. Louis, Missouri, and following that, she completed a fellowship at the St. Paul VI Institute in medical and surgical NaProTechnology. During the week, she sees patients in the clinic, performs surgeries, and delivers babies. On the weekends, she watches Nebraska football. Please welcome Dr. Teresa Hilgers to the NFP Podcast. All right, guys, welcome back to the podcast.
Hi, everyone.
Emily and I are really excited to have with us today Dr. Teresa Hilgers. She's an OBGYN from the St. Paul VI Institute, and she's going to share her expertise with us and discuss the topic of endometriosis. So welcome to the podcast, Dr. Hilgers.
Yeah, thank you so much for having me here. I'm really excited to be with you all today.
Yes, thank you so much for being here. So why don't you give our listeners a little bit of a background? How did you get into this field of being an OBGYN and the work that you're doing at the St. Paul VI Institute?
Yeah, well, it's kind of a funny story because I actually ran far away from medicine. I grew up in a house filled with medicine. Two of my parents, so my parents, Dr. Thomas Hilgers and Susan Hilgers, are two of the co-developers of Creighton Model FertilityCare System. And as you know, the Creighton Model system is an amazing standardized method of charting for women where they can use it to avoid or achieve pregnancy, but also use it for medical purposes with NaProTechnology. And I always loved what my parents did, but to be honest, I saw how hard my dad worked, and he sacrificed a lot for his patients and to develop all this. And I thought, well, I just honestly don't really want to do that. So I went to college to be a history teacher. So I went the opposite direction, took no sciences. I think I took one math class only because they said I needed that for honor society. But it's kind of funny how God works. So eventually I made my way back to medicine and naturally fell in love with obstetrics and gynecology. I think so much of it comes from my parents' work. And I heard growing up throughout the years of how much it had touched women and couples. And so I really wanted to be a part of that too. And I think it's just such a beautiful vocation to have. And I've really received so much joy from what I do. And so I work at the St. Paul VI Institute now. I'm an OBGYN. I did my residency in St. Louis. And then I did a fellowship program in medical and surgical fellowship in NaProTechnology at the St. Paul VI Institute here in Omaha. And I've been at the Institute ever since. I'm also a trained Creighton Model practitioner. So I've learned how to teach women and couples about their fertility by teaching them how to chart. And now I'm pretty active in patient care. I deliver babies, I perform surgeries, I see patients in the office. I'm also train our fellows in medical and surgical NaProTechnology as well. So that's just a little bit about what I do. And one of the things we treat a lot about is endometriosis. Endometriosis is a complex disease, and it's something that a lot of women suffer with. But unfortunately, women's healthcare in today's world is not very good at evaluating for it, diagnosing it, or even treating it. And it's one of the things that we see women battle all the time. And endometriosis is a condition where the endometrial lining, which is the lining that women are supposed to slough off every time they have a period, that lining is only designed to be inside the uterus. So endometriosis is a condition where that lining or tissue that looks like that lining under a microscope find itself outside of the uterus. So that could be on the ovaries or the uterus or the fallopian tubes, the appendix, the bladder, the bowels. It can be all over. And it causes significant pain. But also, it's one of the main causes of infertility as well, or recurrent miscarriages. So women who've had repetitive miscarriages, like 2, 3, even women with 1 miscarriage can have endometriosis. It's a surgical disease, so you have to know how to evaluate for it. And the evaluation requires surgery, but not all surgeons are trained equally when it comes to this. And so that's something that I'm really passionate about, is that we can train young surgeons how to look for endometriosis and then properly treat it as well. So I know I've been talking a lot, so I don't know if there's anything you wanted to ask about that.
Yeah. Before we dive too much into the topic, I want to just backtrack a little bit. So
sure, no worries. I got going.
So
See, I'm so ready.
what was the catalyst to pivot from history to OBGYN? Like, what did you start taking classes and you're like, oh, I'm just not really as interested in this as I thought? Or your mom and dad were kind of nagging you, like, look, you're really not made for this. You should go be an OB. Like, what was kind of the help to get you in the other direction?
Actually, my parents never put pressure on me to be a doctor. So I love history. I still love history to this day. Do you know, the funny thing is, you know how those moments you look back in your life, you're like, I think God was tapping me on my shoulder. So I was a freshman living in the dorm at Baylor University, which is where I went. And I was having a conversation with a girl who lived on my hall who is pre-medical. So she became a doctor herself. And it was like spring semester. And I remember just like listening to what she was talking about, her courses and all that. And I had this one thought in my head that it was literally, I could do that. And so after that, I just started thinking, well, what if I do want to become a doctor? And maybe I should start taking classes just in case. So I added pre-med. I had to work hard to get caught up. And then even after undergrad, I wasn't sure if it's what I wanted to do. So I didn't go to medical school right away, but I got my master's and I worked in a lab and just trying to figure out what I needed to do. And I eventually got into medical school. And honestly, I think it was one of those journeys that took time. And, you know, I've just fallen in love with it. So it wasn't instant, but that was the moment where I was like, maybe I need to rethink this. So it wasn't my parents at all.
So there was a conversation that happened and then you started to turn a little bit. Okay. Because when you're just like, yeah, I was doing history and then stuff happened and I became a doctor. I'm like, wait a second, what? That's a big turn, especially to have kind of a somewhat of a strong aversion to it at first when you entered into college. So, okay. Thanks for kind of clarifying that a little bit.
No worries.
So let's jump back to the topic. So endometriosis in a nutshell is the lining that should be inside of the uterus is growing outside of the uterus in places it shouldn't be.
Right. So it's tissue that resembles it. So it may not be identical to it. There's different criteria for identifying it. The pathologist will look under the microscope. Some will use 1 of 3 criteria to diagnose endometriosis. Some will say 2 of 3, but they have to have structures that resemble the lining of the uterus or similar to it. And that's ectopic. So it means it's in a place where it shouldn't be. And that can be anywhere.
And this is something that can only be diagnosed via surgery. You can't diagnose it with a blood test or with an ultrasound.
Yes, that's correct. So the only way to 100% diagnose it was surgery and then removing a piece of the tissue from the patient where the disease is located and sending that to the lab to be evaluated where you get a diagnosis. Some imaging, like ultrasound, is one of the first routes of imaging we use in gynecology to evaluate for abnormalities. You can sometimes see evidence of endometriosis on ultrasound. For example, a woman may have an endometrioma, which is a cyst filled with endometriosis in their ovary. Those can be visualized by endometriosis, or can be visualized on ultrasound and tell you the woman has endometriosis. But I will tell you, I've seen so many normal ultrasounds where the woman has endometriosis. So it's not definitive by any means, unfortunately. So really understanding who is impacted by endometriosis getting a good history from the patient. So maybe, I love my history. So, talking to patients, let's talk about what your history is. Let's figure that out. Knowing why they're there. Is it for pain? Is it for endometriosis or infertility, recurrent miscarriage? What are their complaints? And then what have they tried to solve it beforehand? And I think the problem with endometriosis ultimately is we diagnose it so late. It takes us, on average, it's thought maybe 7 to 9 years before a woman who presents with symptoms gets diagnosed. And to be honest, one of the main culprits is because we put all our young teenagers and young women on the birth control pill, which is actually the wrong move because it actually doesn't treat endometriosis. It kicks a can down the road for when they want to start having their families, or they stop the birth control. I've had this happen with patients. They've stopped birth control pills to try to start their family, and they're in so much pain they have to go back on it. So it never solved their pain issue, and it definitely doesn't help their fertility. And so then we deal with it later when it's worse. So we have a lot of issues that resolve around endometriosis, but you're right. It can't be visualized 100% on imaging. So surgery is the correct way to identify it.
Yeah, I'd like to hear your thoughts on this. It sounds like based on just anecdotal observation and, working with women and hearing conversations or having conversations with women that I've worked with over the years that have had endometriosis and have had it diagnosed and surgically removed, is that, way back when they went to the doctor, this pain that they were feeling was just kind of brushed off of, like, to your point, oh, you're in pain. Okay, to some extent that's normal. Either they're given this narrative that this is normal, suck it up, it's once a month, it'll go past, or it'll pass. Or, oh, this is not normal, here's the birth control pill to help mitigate the pain, which in some cases it really can help suppress that symptom. But I think the sadder part is just this general idea that women presenting with pain, and often, correct me if I'm wrong, often severe pain when you have endometriosis, depending on the degree of which you have the disease, that they're not taken seriously. It's like, oh, or, and this is something I think in a patient population, I can definitely attest to this too, is like, well, you're just talking about it with your girlfriends. If everyone's sharing, like, oh, this time of the month, I eat some extra chocolate and I lay down with a heating pad, it's like, oh, okay, well, 5 out of 5 of us do this. Right. I guess it's totally normal. And I don't seek, more care. So your normal baseline is set at a level that it shouldn't be, because it's actually not normal.
That's correct. I mean, I see this all the time with women who come to me, and I'm just taking a history from them. And I'm like, wow, that pain is not normal. And they're shocked when I tell them that's not normal. I'm like, what do you mean? I remember one time I had a patient tell me, well, she had severe pain, but she didn't think anything of it. And she was actually there just to establish care and ended up having endometriosis. But I remember she said, well, my cousin is throwing up every month. I'm not as bad as her because I don't throw up. And I remember thinking, well, throwing up is not a requirement for bad pain. And so we have two issues. One, ultimately, actually, we're not well informed in the medical community as to what abnormal pain is. Number two is that women talk and we compare ourselves to each other. It's our natural state. But when you see somebody who's worse than you, then they had endometriosis, and you're like, well, there's no way I could have endometriosis because Susie Q down the road is debilitated, but I'm functional. I mean, I just need to take my ibuprofen every 6 to 8 hours. If I miss a dose, I'm done, but I'm functional and I'm okay. That's not okay either. And the more I've done this, the more I've realized that pain with periods, we have the wrong idea as to what it should look like. It should honestly probably be 1 day of no like mild cramping. It probably shouldn't be more than 24 hours of pain with our periods. We shouldn't have premenstrual cramping. So that's cramping leading up to our periods. But women will say, oh, 2-3 days of pain, that's normal. Ibuprofen Tylenol should take care of the pain. And if it's not taking care of the pain, that's a problem. Then birth control is not your next step. Your next step should be evaluation for endometriosis. The other issue is if women are taking ibuprofen or Tylenol or Advil, whatever it is, around the clock, and they're maxing out those doses, and you'll hear this, women will say, if I'm 30 minutes late taking my next dose or an hour late, I'm done. That's not normal either. So we have to reframe and re-educate women and physicians and anyone in healthcare what normal is like. Because I've heard people tell me their doctors told them they were crazy. It was in their head. This is normal. You're making it up. A lot of women feel vindicated who have pain once they find out they have endometriosis, and it takes them doctor after doctor to get to it. So in a day and age where we're all about women's healthcare, when you look at it, we're really not. We're really not taking care of these major issues for women like they deserve to be taken care of.
Right. So there's kind of attacking it at two ends, right? Like the boots on the ground patient population and then the medical professionals as well,
Right,
trying to educate them
exactly.
better. Yeah. So let's
Yeah.
go over symptoms of this
Yeah.
disease. We've talked about pain already quite a bit here. So
Yeah.
someone walks into the office, girls walking into the office or an adult female is walking into the office and is having what? What would she present with? Are we talking irregular cycle? Her periods are off. She's having pain. She's what? What else?
Yeah, so there's a lot of different symptoms that can be associated with it. So pain is the most obvious. Sometimes
And I'm
women
sorry,
can,
Dr. Teresa,
yes,
Dr. Hilders, can you
yeah,
clarify where and when are we having pain? Are we having
yeah.
pain middle of the cycle? Are we having pain at the period? Where are we having pain?
Yeah, so the most common is pain with the period. And typically women will say cramping. It can be in the abdomen, it can be in the back, it can be down the legs. Um, but women can have pain throughout their cycle. Some women have every day of the month. They'll have pain. Some women will have significant pain around the time of ovulation. So we talk about that maybe you can have pain for a few hours when you're supposed to ovulate. Around that time, it's called middle Schmerz pain. But
Excuse me, one more. Is
yeah.
it during intercourse as well?
Yes, yep. So if you're having deep pelvic pain with intercourse, that is another symptom. However, there are other symptoms as well. So infertility, even without pain, is a symptom of endometriosis. Miscarriages without pain is a symptom of endometriosis. So my father, I think one of the brilliant things he did with NaProTechnology is he was really invested in trying to figure out what women were dealing with and what was causing their issues. Like he wanted to figure it out. And one of the symptoms that a lot of women came to him with were, I cannot get pregnant. They were having infertility. And so he was really dedicated to figuring out what was causing it. And one of the things he did a study where 250 couples came to him with infertility, and it didn't matter if they had pain or not. He did a laparoscopy on them. Now, laparoscopy is a surgery. It's an outpatient procedure, pretty low risk, where we put a camera in that through a small incision in the abdomen. We look around. So he was evaluating for why are they having infertility. So 250 couples came to him. Every one of them got a laparoscopy. Do you know that 72% of those women had endometriosis? Over 70% had endometriosis. He didn't base it off their pain. He didn't base it off anything else. It was just, were they having trouble getting pregnant? And that was his criteria for doing a laparoscopy. So fertility abnormalities without pain are also a symptom of endometriosis. And I have seen stage 4 endometriosis. That's the worst type of endometriosis in women with no pain and their only issue is infertility. So the pain doesn't always line up with the severity of the disease. And if a woman is having infertility, endometriosis should be one of our top things we're worried about.
Now, what about for our young girls who are not engaging in intercourse, not interested
Mm-hmm.
in, trying to get pregnant, but they want to ovulate because ovulation is healthy. We want to
Right.
preserve ovulation. And maybe they're in that category of not experiencing a lot of pain. What would be some other symptoms that they might present with? And we can even refer to, cycle charting here. Emily and I talk
Yeah.
about that a lot on the podcast. We talk about the different phases of the cycle, what are healthy patterns, what are unhealthy patterns. So would their chart look different, with someone who had a healthy reproductive
Yeah.
system versus someone who didn't?
It's a great question. So I'm a big advocate for charting, and I think our adolescent women, those young girls, need to learn how to chart their cycles. So with the Creighton Model chart, there are abnormal biomarkers that can appear on the chart, and that can be limited mucus. So women create mucus around the time of ovulation. So as the follicle develops, it produces a hormone called estradiol, and that stimulates the cervix to create the cervical mucus. And it should be present for about 5 to 6 days. And there's a certain quality and quantity related to it. But in women with endometriosis, they often have a decreased mucus production. So they have a limited mucus cycle. So maybe they have 1 or 2 days of mucus or very poor mucus, where they can barely see it, but it's there.
And is
So
this
that,
because, I'm sorry to interrupt you, just
no, go
really quick,
ahead.
because it's pertinent to this
Yes.
exact point. Is this because the endometrial tissue or the tissue like endometrial lining that's in a place it shouldn't be is kind of confusing the body with not so that communication between the brain and the ovaries and the uterus, they're not able to communicate correctly to get the hormone signaling right. Is that why? Like the tissue in
No,
other places is interrupting the communication line, or what's causing that?
no, it's a good thought, but that's actually not quite correct. So
Okay.
the cervix has receptors for estrogen in the cervix,
Okay.
and these receptors, there's a deficiency of them or they have a defect to them.
Okay.
So there's an estrogen receptor defect present when women have endometriosis. It's probably, we don't know 100%, but I would venture to guess, if I could, it's probably related to the inflammatory nature of the disease. Also, there are a lot of hormonal abnormalities associated with endometriosis. Women with endometriosis have high rates of premenstrual syndrome because they have abnormal hormones as well. The ovaries don't like stress. Endometriosis creates a stressful environment. And so after ovulation, for example, the ovary is supposed to produce progesterone, estrogen then as well. And premenstrual syndrome is a result of abnormal hormones, usually after ovulation. Beta endorphins play a role in that too. I won't get into that 100% here, but we'll see that frequently with women with endometriosis. So another thing we can see on their chart is a short post-peak phase. So the luteal phase of the cycle is very short because a woman is producing a low quantity of progesterone. So she starts her period really quickly after ovulation, maybe 6-7 days. That could potentially be a sign of endometriosis. You don't see it as frequently. And then unusual bleeding patterns can sometimes be associated with endometriosis. So brown bleeding at the end of the periods. It's amazing how many women don't know that brown bleeding at the end is abnormal. Whenever I bring it up to women, they're like, well, I've had that for years. That's not normal. Or some women didn't even know they were supposed to pay attention to it. And that's a beautiful thing about charting. I've had a lot of patients tell me, wow, I had no idea my body was doing this until I was basically asked to pay attention. So if you just pay attention to your body, it will tell you things. I always say the chart doesn't lie. We just sometimes don't understand it. You know, it's trying to tell us. But abnormal bleeding can be associated with endometriosis as well. And that can have various patterns. So for a young girl, going back to the young adolescent, you know, I think for them, it's really important to get them charting. And if they have pain, you know, you can start small with Tylenol and Advil, like just see if that takes it away. But, you know, if they're still having pain, when you're doing these small interventions, I have a very low threshold for endometriosis. And we see endometriosis. I've seen it in young as 14-year-old girls who've needed surgery. And we know endometriosis can be present even earlier than that. There's places where they found endometriosis in girls before they even went through puberty. So, I mean, it's present. And if you get on top of their endometriosis correctly as a teenager, you're going to not only protect their reproductive organs, you're going to help protect their future fertility and their quality of life. So there's so many benefits. The one issue we have is you do have to go to the right surgeons for this. So not everyone is trained in surgery. And so some women, unfortunately, don't get good surgery, and that can damage their reproductive organs as well. So we're walking a balance because we don't have enough surgeons right now who can really do this in a way to protect the reproductive organs, but I think we need to advocate for it.
Right.
Yeah.
So, okay, so it sounds that, I mean, that was really helpful, I think, for our moms and our younger, you know, women or women who are just older and just not sexually active. And so maybe, you know, painful intercourse or infertility are not going to be symptoms that they would present with.
Right.
But maybe if they're charting, if they're tracking their cycle, they can start to see some of these abnormalities. And to your point, like, it's funny how I do this too, how like the timeline can establish normality as opposed to like what is like healthy is establishing normality. Emily and I talk about this in like other aspects of health. It's like, well, for years, it's just been really hard for me to do this activity. It's like, but it shouldn't be like, you know, if we moved better, then that wouldn't be an issue, you know, that type of thing. So anyway, we find that here in the world of women's health as well.
Oh yeah, absolutely.
So let's move into, I guess, a little bit. Okay, so kind of understanding symptomology, how things present, and maybe into treatment. So you touched on a little bit why
the hormonal birth control. And we've had other, medical professionals on to talk about this too. Emily and I have beaten it like a dead horse as well. It's not the best treatment option. While we do acknowledge it can help certain women, mitigate symptoms and pain and things, but you're not addressing the underlying cause of set pain, right? So we always say it's like the Band-Aid approach. You're putting a Band-Aid on it. And again, and that's because of this mindset. Well, I would say, I don't know, it's in my experience again, like the mindset seems to be, well, you're not trying to get pregnant, so this isn't an issue yet. It's like, and again, right. And we go back to, no, we should be ovulating every cycle, regardless of pregnancy intentions. Ovulation is a sign of health. We want to preserve ovulation. We want to have healthy periods, et cetera, et cetera. So maybe let's talk a little bit about like what are corrective approaches? Like how do we then not put a Band-Aid on it? What do we do? What does that look like to restore healthy, reproductive systems?
Well, I think it's a great question. And we want to just go back to the birth control real quick because, when we talk about our young girls on this, so, I mean, girls are being put on the birth control at 12, 13, 14, 15 years of age, right? Really young. So their cycles are irregular. They have heavy bleeding pain, whatever, acne, whatever it is. And I always think, when we talk about good medicine, it has to really, I think, it has to meet two criteria. One is actually good medicine. Does it actually do what it says with low risk to the patient? Is it beneficial to the patient? Does it actually truly help? And two, I always think that there is a certain ethic behind medicine that is appropriate that we need to maintain. And when it comes to birth control pill, if you really dive into it, it's actually terrible medicine. And so when we talk about it can mitigate symptoms, it sure can, but it doesn't actually regress the disease. So the studies never show that it regresses the disease of endometriosis. The other thing too, that I think this is really important for moms. There are risks associated with the birth control pill. And one of them is an increased risk of breast cancer. And it's higher in women who start the birth control pill before their first full-term pregnancy, which is almost every young teenage woman out there, right? It increases our risk for premenopausal breast cancer. And our breast cancer rates are actually going up. They're not going down. And so I always think if I were a mom and I had a daughter with pain or acne, whatever it is, and I was told to put on the birth control pill and I was told, hey, this will solve everything, I would be, yes, help my daughter, right? But if I was told too the risk, I'd be like, wait, is there something else out there? So that's just something about the birth control pill. I think a lot of women don't know, a lot of moms don't know. And I think we should be really protective of our young girls and their future health. So the correct
and teaching
treatment,
them too. Sorry, Dr. Hilgers.
No, go ahead.
Teaching them too that your hormones are good. Like we want good hormones flowing through your body during the whole of your reproductive life. This is good for your brain, your heart, your bones, everything. Like this is a good thing. We don't want to suppress it or introduce synthetic hormone concoction, which is what's in the birth control. So,
That's right. Right. No, that's exactly right. And I think too, we can't be afraid of medical problems. I think in the medical world, it's like, we just need a quick fix. It's like, no, sometimes you have to dive in and figure out what is going on and let's solve it. So for the young girl, there are different things you can do to help them. So if they're having pain, ibuprofen, Tylenol, I always start there. And I'm to the point who I just know a little bit. I think you just need surgery. You can tell what they're already doing and you get a good idea. But let's say somebody hasn't tried ibuprofen or Tylenol or, Aleve or Midol, whatever it might be. I would say, let's put you on these things and let's see how you do over the next 3 months, 6 months. I get them charting their cycles. I'd evaluate their hormones. A lot of times these girls have abnormalities in their hormones too. And if they still were having pain, I'd say you need surgery. So the proper way to evaluate endometriosis, like I said before, is surgery. You really need to cut the disease out, but the one difference with surgical NaProTechnology, which is what I practice, is we are very protective of the reproductive organs. And when we do surgery, our goal is that we correct the underlying disease, whatever it is, endometriosis, scar tissue, whatever it might be, but we're going to preserve the reproductive organs and we're going to reconstruct them to make them as close to normal as we can. So a lot of times if we have surgery for gynecologic issues, it's done in a way where endometriosis may not be, number one, treated properly. So they might be going under a procedure called cauterization or fulguration of endometriosis. Or ablation. Those are the three common terms where they just burn the lesions of endometriosis. That is not a good way to approach endometriosis. It has a very high recurrence rate, 50 to 100% of the time it will recur. And a lot of times the disease isn't treated 100%. So you can't burn on the bladder or the bowels. And so, I saw this as a resident. We would treat endometriosis this way. And guess what we left behind? Oh, that's in the spot we can't burn. We're going to leave those lesions behind, but we'll treat everything else that we can. So a lot of times you're getting incomplete treatment and you're treating in a way that's not good. And so you have a high recurrence rate. Excisional surgery is the gold standard. That means we cut out the disease, but women are at risk for forming scar tissue with endometriosis surgery or any other type of surgery, and that can cause pain too. So scar tissue is where there's an abnormal connection between two organs that normally aren't connected. So let's just, for example, the ovary and the bowel. You can get scar tissue between the bowel and the ovary. Well, imagine that can cause a lot of pain. Those are mobile organs. They move a lot. And so that causes a lot of pain that can negatively impact fertility down the road. And so what we see is that a lot of surgeons or a lot of OBGYNs will say, well, surgery doesn't help because women still have pain afterwards. Well, they're still having pain because most likely their endometriosis wasn't treated correctly in the first place. Number two, it could have been done in a way that creates scar tissue, which also causes pain. So in my patients, I see in general, now we really need to study this, but in general, I see a 50 to 100% pain reduction within 3 cycles after surgery. If we don't meet that criteria, so like I always talk to patients if they're still having pain, because I've had patients I've operated who had no improvement. Any doctor who tells you all their patients have pain improvement, they're lying, because pain is difficult. And so we still have things we need to learn about pelvic pain and disease, but diet plays a role and our muscles play a role. So physical therapy can be really helpful as well. So there's a certain group of women who need dietary changes and physical therapy to help retrain their muscles because they've trained their muscles subconsciously to work in a way to be protected. But now they're tight. Now they're using them improperly because it was a protective mechanism gone wrong. And so we have to retrain those muscles. And so, we can really improve women's lives with this pain reduction. So I have a lot of women tell me after surgery, I use way less ibuprofen Tylenol than I ever did. I don't need any. I'm significantly better. Yeah, I have a little cramping, but it's no big deal. And it's just really marvelous to see how their lives improve. And so for a young teenage girl too, or a college age woman, I think those are important too, that if they have the right surgeon, they can have significant pain relief. But this is where we get away from surgery because a lot of physicians, aren't trained properly in endometriosis. So they don't know how to identify it. They don't know how to treat it properly, treat it on difficult places, like the bowels or areas that are of concern that you have to know what you're doing to treat it there. And I can, vouch for the failure of the medical system to teach us what endometriosis looks like because I think I went to a very good residency program and we did a lot of surgeries. And I thought I knew what endometriosis looked like at the end of that residency program. I came to fellowship. And do you know my first 2 months here? In fact, I trained my co-fellow did residency with me. The first 2 months, we would often look at each other and go, did you know endometriosis could look like that? We had no idea. And we had done a 4-year training in OBGYN. And you have to really know what you're looking for. And unfortunately, we're not taught that in residency to the point where we really need to be. So a lot of OBGYNs may think they're good at endometriosis when their training's just been subpar.
So why only surgery? Why is surgery? Because I think, and rightly so, as a patient, someone says surgery to me, I think, oh, like anesthesia.
Right.
I mean, that's something we're always told, like you do kind of want to avoid having a lot of surgeries.
Right.
It's not something you want to just kind of be going in willy-nilly and having. So why is it that surgery is necessary? Is it only necessary for, the different stages, the different categories and degrees of endometriosis? Are there just pure lifestyle, supplement, hormone, supports that can either suppress or get rid of the disease if it's at a lower stage? Those are some of my questions that I have. Another one.
It's a great question because a lot of women will say that. And you have to explain it. I've had patients go, "You want me to have surgery? Like, are you kidding me?" Like, now, if they're in a lot of pain, they actually expect you to say that because a lot of times, by the time they get to me, they've done their research and they know. But for some of these other things, they're surprised, especially the women who are like, "My pain's not that bad," because, like I said, Susie Q's throwing up. I'm not. Yeah, I'm listening as their doctor going, "Are you kidding me? This is outrageous what you're going through. This is not normal." Um, sometimes without patients like that, we have to educate them. But endometriosis is currently a surgical disease. So that means two things. One, it's diagnosed surgically, and two, it's treated surgically. We have no medications out there that suppress endometriosis. Now, we will be told there are medications such as Lupron or Elissa, which shut down the menstrual cycles and the hormones. We're told that suppresses endometriosis, but actually it doesn't. The studies really look at the symptomatology, so it's to improve your symptoms. And they can improve their symptoms. There's a lot of nasty side effects associated with those medicines, but the only way to prove if these diseases are suppressed with hormonal contraception or these other medicines like Lupron or Alyssa's, you do a surgery, you see what the endometriosis is, then you put the woman on the medication, and then you come back while she's on the medication 6 months later, and you should see a regression of the disease. The way they do it is they either follow the woman with ultrasounds or symptoms. And my dad actually in the 80s, he did that with one of the medicines. So it was danazol was a medicine. He put women on it. There's a lot of side effects. So at that time, danazol was one of those medicines touted as, hey, you put this woman on this or endometriosis will be suppressed. And he talked to these women and he said, well, why don't we do a laparoscopy while you're still on the danazol? And do you know their endometriosis was still there? It did not get rid of their disease. And so the studies aren't done properly. There are things you could do to improve pain. So there are different supplements you can take and diet changes, but that doesn't get rid of the disease. And so it could still have negative impact on future fertility. The disease is progressive, so typically worsens. It can stay at a certain level the whole time, but it's typically a progressive disease. So depending where it is, it's only going to get worse. Now, how quickly, how slowly, we don't really know. And interestingly, I read a study, it was like a couple of years ago, where they compared 5 different routes of medications for decreasing endometriosis. So one of them was combined oral contraceptives, one was danazol, one was Lupron, one was actually N-acetylcysteine, which is a supplement a lot of endometriosis doctors will recommend for their patients. And it looked at women with endometrioma, so those cysts in those ovaries, and how quickly they decrease the size of those cysts. I was shocked by what I read. So they looked at different studies. So it looked at a bunch of different studies within the literature, and it showed the earliest regression started at 18 months after starting the medication, which is a year and a half. But it could take up to 5 years, and they would see only maybe 1 to 2 centimeter decrease in size of the cyst. So it didn't get rid of the entire cyst, and the cyst is still there. And so for a woman with pain, you're gonna make me wait 18 months before I might see any, improvement. So right now we just don't have a medicine that really treats it. And so that's why surgery is our current route.
Okay. How about cause? What causes this?
Oh, that's a huge debate right now. So the old theory was retrograde menstruation. So women menstruate, it comes out from the uterus to the cervix to the vagina. Retrograde menstruation means that some of that fluid comes back out through the fallopian tubes and then ends up in the pelvis. And you can see that during a laparoscopy. We often operate when women are on their early in their cycle, so they're typically menstruating when we're operating. And you'll see some blood in their pelvis. So the old theory was that retrograde menstruation would occur, and then that fluid would implant in the pelvis. And that's how you got endometriosis. Well, women get retrograde menstruation. Not every woman gets endometriosis. And there's one doctor, I remember Dr. David Redwine, who is an endometriosis specialist. He used to say, you've never proven that this actually implants. So he would say that theory probably isn't a very good theory. There are other theories too. One is embryologic, like we're born with it. Number 2 is it spreads through our different, like our lymph systems, or there's a transition of the tissue into endometriosis. Some people think it's an autoimmune condition, so we don't really know the exact cause. Every theory, you could probably explain each patient with maybe one or two of the theories, but I don't think any of the theories truly explain it. Believe it or not, men can have endometriosis. So retrograde menstruation doesn't work for them, clearly. So why do they have it? There's some thought, could there be a genetic component? We see it run in families. Mothers often, a lot of our patients now, it's not common. I should say the Institute's been open for 40 years now. So now we're getting daughters of moms who came here, and they bring their daughters in very quickly because they start to see the symptoms they had and they knew what problems they had, and they want to get their daughters taken care of, which I think is awesome. And we can get on top of it early. But we'll see sisters, you'll see it run in families as well. That's probably one reason, since we don't know the exact cause, that we don't have a good treatment for it outside of surgery. Because how do you target something that you don't understand its cause? And, the research is really going into the development of the birth control pill and all that. We're not really putting a lot of money into research behind what's causing endometriosis. So I think we're putting our money in the wrong place.
And it's an inflammatory condition. So is it true that often some lifestyle adjustments that can, that promote anti-inflammatory effects on the body can help with the symptomology and the management of that?
Absolutely. So I've had patients who put themselves on diets, before they had surgery or something like that. They had pain improvement. So it can definitely improve pain. It is a very inflammatory disease. So it creates a lot of scarring. That's one of the reasons it contributes to infertility and recurrent miscarriage. So diet can definitely play a role, especially in women who I really love diet changes in women after surgery if they're not getting great pain relief. Women with IBS or irritable bowel syndrome, believe it or not, a lot of those women have endometriosis. So we see the bowels impacted a lot. Doesn't mean the endometriosis is located on the bowels, but the bowels live in the pelvis. Their next door neighbors are the pelvis. So our bowels love the uterus, ovaries, fallopian tubes. And so if they're angry, your next door neighbor is angry. So the bowels get angry too. And so you'll see a lot of irritable bowel syndrome symptoms in these women too. So dietary changes can be really helpful. Mm-hmm.
Oh, that's so interesting. Okay, Emily, I have totally monopolized. Jump in here. Do you have questions? Things I've forgotten?
You're so good. Yeah, no, I'm just so curious, how often do you see these women that, they've had a laparoscopy and they've been told you don't have endometriosis. I hear that so often just working with women and couples. And, like you said, I think that they are validated when they come to you, but there's also so many other emotions. Like they've been down this whole journey, especially if they're trying to have babies. And so I just wondered how often you see that. And do you think that's because doctors don't, back to your point, they don't know what endometriosis can look like?
Yeah, it's a great question, Emily, because we'll have patients come to us, and even with pain, we've had women with severe pain come to us, and they've had negative laparoscopy, which means a normal laparoscopy or normal surgery once, twice. 3 other surgeons have looked, and they told normal, and they have endometriosis. So we actually looked at the numbers of our patients who came in with a normal laparoscopy, and then we did surgery on them. And I am drawing a blank on the exact numbers, but it was a vast majority. It was well over 50%. I think it was like 80 or 90% of them actually had endometriosis. So we prefer to do our own laparoscopies at our institution. And really it speaks to 2 things. One, endometriosis is a difficult disease. It can be very tricky to identify. And if you're not familiar with what it looks like, you might miss it. But number 2 is how we do the laparoscopy. So at the Institute, we do near contact laparoscopy. So you have to get the camera in really close and look at the pelvic sidewalls. Like you have to take an overview first. So what does the uterus, ovaries, the fallopian tubes look like? A global picture. But then you have to zero in and get really close to the tissue. And you almost want to magnify that tissue because you're looking for the obvious, but you have to look for the subtle too. And some of these diseases, these lesions, you won't see from far away. You have to be really close to tissue. So we read a lot of operative notes from other physicians. A lot of times they just comment uterus, ovaries, fallopian tubes, normal. And you'll see the pictures are far away. They're not close enough. So the techniques that we're taught aren't good enough. And you have to be very systematic. We do it the same way every time in our evaluation, so we don't miss any of the organs. And also, we're doing a thorough evaluation. The other issue too is a lot of doctors only look in the pelvis. They don't look at the appendix, the small bowel, the upper abdomen, where you'll find endometriosis on the diaphragm 5% of the time. So it can really, it's a pelvic disease, but it's an abdominal disease too, because it can go in the upper abdomen. So we just have so much education we have to do in the healthcare world as well, of our healthcare professionals. And it's patient education, healthcare education too.
Can you talk to the mom that is listening and her daughter's in pain and she realizes, you know what, she might need surgery? Can you just explain to her how I can imagine the hesitation. I get that, but what she's doing for her for her daughter's long-term reproductive health by just being a little open-minded or going to get an evaluation or talking more about it with her doctor?
Well, I think number one, I can understand that hesitation. I think you're always want to be protective of your children. There are risks associated with laparoscopies, but for the amount of information we get from them, that risk is relatively low, especially because our patient population is young and healthy. These aren't 80-year-old patients who have like heart disease and, whatever else. Most of these young women have very little medical conditions that might increase the risk of surgery. And the type of surgery we're doing is relatively low risk as well. Every surgery has risk, so I don't want to say it's zero. It's not zero. But I think there's two things. One, we need to understand what's causing their pain. So I always tell patients, or I tell them frequently, it's very difficult to treat something if you don't know what it is. And so pain can be caused by 1,000 different things. Endometriosis from the GYN's perspective is one of the top things we think of, but there are other causes of pain. So if we say it's endometriosis and we put the woman on the birth control pill because, it's endometriosis, you need a birth control pill. What if it's not endometriosis? What if it's a current culprit? Then we're treating the wrong thing. And so when we take patients back to the operating room, our normal laparoscopy rate's only 6%. So we're pretty good at identifying who needs to go to the operating room and who doesn't. But I tell those patients, we tell them there's always a chance your laparoscopy is normal. But that is also good because now we know it's not endometriosis or it's not scarring. Your pain is caused by something else. Now we can actually focus on that instead of spending our time saying, it's endo, when you don't have endo. So one, getting the diagnosis is always important for your treatment. Two, really, I think you're protecting these young girls from, chronic pain and their future fertility. And we have very open conversations with our teenagers, at least I know I do, about, hey, when you get married, you may have issues with your fertility down the road. So we're opening their minds to what struggles they may have down the road, not to scare them, but really just to prepare them. So if they do have infertility, they're going to come back. They're going to seek help sooner. Because one of the problems we have is women with infertility, they wait 5 years, 7 years, 10 years before they see a doctor. And you're like, oh, no, don't wait that long. Now it makes it harder. And I've had a group of girls who I've operated on high school and college age who have now got married. And, we have very frank conversations about these are your risk factors for infertility. And it's amazing. They've either had no problem getting pregnant, or if they did, they're coming back to me really quickly. They know within 6 months to a year, because I always tell them 6 cycles of fertility focused intercourse. If you're not pregnant with the Creighton Model chart, that's infertility. Come back. And then we can work on what else might be wrong and get it corrected and they can achieve pregnancy. So I think if we approach it from this matter, we can improve their pain, but we're going to hopefully protect them from the long suffering of infertility, which is a really hard condition for couples.
Yeah, it is. And I guess maybe we can wrap up by talking about the case of infertility. And this is something that I know Emily and I both talked about on the podcast before, is we actually just had a woman on sharing her story who kind of went through something similar, where you're seeing a doctor and it's almost, I don't know what it is. It's almost like a veil of like this barrier of understanding that like your doctor is not well trained in, I I don't know, for whatever reason, I feel like some women I share that with, and they just can't imagine that. Like, well, no, like all doctors receive the same training. So I want to touch on that as like a real point of importance to say your doctor might have run all these tests. Your doctor might say things like normal. If you don't feel things are normal and you're still in pain or you're still not able to get pregnant, let's go somewhere else. Like try someone different, see if there is a different option. And I forgot the second point I wanted to bring. So let's just start with that one.
I think it's a great point that you make, because I get that from patients. I see new patients for infertility and they've gone somewhere else and they say, well, they already ran all these tests. And I'm like, they didn't run what I needed. And I think that's a beautiful thing. Like, I'm going to go back to Creighton Model NaProTechnology. So Creighton Model, it gives us an objective way of looking at the menstrual cycle. And women, we're amazing in that our hormones are very different than men, and they're very dynamic. They change. They are not stable from one day to the next. So if you get one day of hormones, you're not getting the whole story. And so the beautiful thing about Creighton Model charting and the research my dad did is he developed what the normal hormones are supposed to be before ovulation, after ovulation, because we can actually evaluate the menstrual cycle in a targeted evaluation. And that tells us so much. So a lot of women, when they come to me, they're like, oh, I've had all this hormone testing. Well, they've had one day and it doesn't tell me what I need. But it's really important to just let them know, like, we need to do the proper evaluation. A lot of times my patients will say, wow, wait, this is way more thorough than I ever had before. And they thank me for being thorough. And that's just our approach. Like, we want to be thorough, but it's true. Our training in infertility is not great in residency program in OBGYN training at all, or medical school, you get hardly anything. So really you have to think about the OBGYN training program. And a lot of times you're told, well, the women will be coming off the birth control if they're not pregnant within 1 year with using unprotected, random acts of intercourse, unprotected. So no condoms, no birth control, whatever it might be. Because let's face it, most people are using birth control. And if they're not pregnant, then you do some labs and ultrasound. Maybe you put them on Clomid or letrozole for 6 cycles if they're not pregnant, intrauterine insemination if they're not pregnant, IVF. That's like the algorithm. But it's very poor. The algorithm is terrible. And so we don't even get to the diagnosis. A lot of women will say, I don't actually know why I'm not getting pregnant. They don't know why I'm not getting pregnant. Well, it's true. Those doctors don't know why they're not getting pregnant. There are many reasons why women have infertility. Endometriosis is one of the major reasons. Hormonal abnormalities, ovulation abnormalities, mucus abnormalities, charting abnormalities. Some couples are just not having intercourse on the right days. And you've probably seen this when you teach women how to chart. All of a sudden they're charting 2 cycles in, they're pregnant. And like, how am I pregnant? Well, you just used the right days for once. You actually understood your body. And I remember one time I had a patient, it took her 2 months. Now, she wasn't quite infertility. She was a nervous Nelly. She was convinced she had it. I think it took them they were 8 cycles in. And I was like, you just need a chart. And 2 months after charting, she was pregnant. I remember she said, well, who knew? All I needed was a Creighton model. And I thought, well, it's true. So that validation is always fun. But, in medical school and residency, OBGYNs aren't even taught what normal mucus is like. A lot of times we're taught any abnormal discharge is abnormal, give them an antibiotic, whatever it might be. We don't even understand the physiology of the menstrual cycle like it should be. So, no, all doctors are not trained the same. And I'm not trying to say doctors are terrible. I'm not trying to say that all. So please don't get that from me. But what I am saying is our education has not been good. And the only way these doctors are going to learn is if they have an invested interest in their patient and getting to the root cause and the bottom of the issue. And our healthcare system is such that our appointments are 10 minutes each. And so infertility, pain, those are really complex issues. You really require longer appointments to get to the bottom of it. So a lot of doctors just don't have the time to do it. And they don't have the training or the education. So you really need to seek somebody out with that training, that education. And I'm a big proponent of NaProTechnology. I just love its approach and its ability to care for these women and couples when it comes to whatever it might be, whether it's infertility, miscarriage, pain. Premenstrual syndrome is one of my favorite things, to get across. Real quick on the pain issue, I did also just want to mention for the polycystic women out there that they can have pain associated with endometriosis. A lot of times doctors will say, well, you're polycystic, you can't have endometriosis. But we have found that 50 to 75% of women with polycystic ovarian disease have pain, have endometriosis as well. So that's a common misconception. And I didn't want to leave those women out either. They have long, irregular cycles, but they can have a lot of pain. And so they deserve to have that addressed as well.
Yes, thank you for mentioning that. Now, what about women who, this is the other one I remembered.
Yeah.
Women who have had children who still have endometriosis. What about that population? I feel like that's, again, something when I've talked to women and they share like some serious pain issues and cycle issues they're having, but they have children, they have multiple children, and maybe somewhere in there they had miscarriage, but not always. Again, I think I used to view it as just like babies. Babies is the reason we want to have cycles. And now, yes, babies, great. Definitely want babies. But I also just have learned so much about like, no, we just want hormones. We want ovulation. This should be healthy. You shouldn't be in pain. I care more about like the health of the overall cycle, regardless of the baby outcome. It's like, we just want you to not be hunched over every month.
Right.
That's not normal. So how is that possible? If a woman could have this and then she's still getting pregnant, do we know?
Well, endometriosis is a funny condition because we'll see terrible disease in women who had no problems getting pregnant, no miscarriages. And you're just like, but this is the exact same pelvis in somebody else where they're going to struggle to get pregnant. So it shows you a little bit of what we still have yet to learn. But we'll operate on women who've had babies before because of their pain. Interestingly, too, you can have secondary infertility with endometriosis. So you might get pregnant 2 times and then you can't get pregnant, or you have a bunch of miscarriages. Endometriosis is still a likely culprit. One thing we think about is, could it be related to age? Did they have their babies when they were younger and then they kept having their babies? So they were able to overcome maybe the disease, the negative impact of the disease because they started early. Many times these women have their children when they're younger, but not always. So again, it's not 100% why. I would say these women still deserve a chance to be evaluated and the potential for quality of life. Even if you're in your late 30s or let's say early 40s, menopause on average is around age 50, 51. So we don't know when a woman will go through menopause, but let's say you're 40 and you're in a lot of pain. Well, you might still have 10 years of pain and you might say, I'm done having children. Well, a hysterectomy may not be the right answer either. And a lot of times that's what's happening is women who are perimenopausal get a hysterectomy. But if you don't get the disease out, a hysterectomy doesn't solve it. We see a lot of patients who've had a hysterectomy, they come back to us because they're still in pain because the endometriosis is actually left behind, or they get scarring from the hysterectomy. So the only way hysterectomy solves the pain is if it's only localized the disease to the uterus and the cervix. If it's outside of that, then that disease has to be removed too. Otherwise, that woman will still have pain. So I would just say those women still need, I would still recommend they chart, get their surgeries, get their hormones straight around. Premenstrual syndrome is a major issue with pain. And I hear a lot of moms say, when I'm premenstrual, I feel like the worst wife, worst mother, because I take it out on my kids and my husband, and that makes them feel 10 times worse. The other thing too about hormones, I think it's really important to get the hormones straightened around in women with endometriosis, because think about it, you're going to be in pain with your period, right? But if you have hormonal abnormalities and you're struggling the week before your period starts, now it can be irritability, carbohydrate cravings, crying easily, but it could be fatigue or insomnia. So you're already emotionally drained before your period and all that pain hits. It's going to be harder to deal with that pain. So we have to attack it from every aspect is kind of how I look at it. So these 40-year-old women, 45, whatever it might be, they still deserve the opportunity to chart, get your hormones straightened around. Let's look at your pain and what's causing it. And let's just help you have a better quality of life. Normal hormones is very important for our bones, our breasts, our uterus, all of that. And so we've basically devoided women of normal hormones for decades now. What is that doing for our long-term health? And I think we don't still understand those consequences. So I totally agree. It's really important.
Right. Yeah. Thank you so much. I'm so glad you brought that up, that regardless of your age, really, we want you having healthy cycles.
Yeah.
And I don't want it to end us on a false note, but I was thinking, so a kind of a big takeaway from this is if you're struggling with irregular cycle, patterns, irregular bleeding, or even if you don't know what regular is, maybe you're listening to this and you're like, I don't know if this is irregular. Isn't? Go back and listen to some of our other episodes because we talk about what normal, what healthy cycle patterns are. Get connected with someone that teaches you how to chart and monitor your cycle so that you can understand what's healthy and unhealthy so you can monitor that aspect of your health. But in a nutshell, I guess I would just say with endometriosis, there's just still so much that we don't know. And so if you keep getting told everything looks fine, but you're having issues, just don't rule it out is basically what I kind of got from this whole, I got a lot from this conversation, Dr. Hilgers, but one of the big things I got was you can't rule out endometriosis until you've had a surgery and now you're able to rule it out. Would that be correct?
Right. That's correct. And, one thing we do at the Institute is we videotape our surgeries. And we actually show it to the woman so that
I've seen mine. It was quite startling. I was like,
so no, it's like amazing because then the woman sees, oh my gosh, this is abnormal. I see it. Or if they're normal, they have video evidence. They can take it to their next doctor. If they don't believe them, they can watch it, so I think it's just really important that patient education is so important. And the last thing really is, doctor is actually Latin for teacher. And we've lost a lot of that in medicine. And so our job is we have to understand the disease ourselves. We have to evaluate, treat, but we have to explain it to the patient. Mm-hmm. And you're completely right. It's okay to get a second look, second opinion. You might need another laparoscopy. That's okay. It's not the end of the world. If you have to get a third or a fourth opinion, that's okay too. But you really need to find somebody who knows what they're doing. And not all surgeons are equal or all doctors are equal. And that's important.
And so you really recommend if, we have patients listening, this designation of medical, surgical, NaProTechnology trained physicians. Is that correct? Okay.
Right.
And we'll link to the Institute website and where people can look up those trained physicians. They are, kind of scattered a little bit throughout the country. They're, to your point, they are kind of few and far between when we look at the whole of the medical professional world, but they are out there. So getting help as early as we can and just not to rule it out. I just feel like I still know women who are miscarrying frequently, have gone through all these things. And I'm like, have you gone to this doctor? Like, just let's switch and just get, what's it going to hurt? You really want to have another baby. Like, let's just, try this other thing. And there's still some hesitancy there. So
enjoyed our hour together. It was really fantastic.
Me too.
Thanks for all the great questions.
Yeah. Thank you so much, Dr. Hilgers. All right. We will see you guys in the next episode. Bye, Emily.
Bye.
Creighton Model, charting, fertility care, all those resources we've mentioned before on the podcast, but we'll link them with this episode. Thank you so much for your time, Dr. Hilgers, for getting up early with us. I really appreciate it. I know this is going to help a lot of people. And so, best of luck in all of your endeavors. Thank you for all your hard work. We really appreciate it too, just as women in this world, having more people to help, get our systems working well so that we can be healthy regardless of our pregnancy intentions, just so we can be healthy women as a whole. So.
That wraps up another episode of the NFP Podcast. Thank you so much for joining us today. We hope you found our discussion enlightening and empowering. Don't forget to subscribe so you never miss an episode. We'd love to hear from you. Please connect with us by sending us an email with your questions and stories to thenfpshow@gmail.com. We'll be back next week with more insights, tips, and heartfelt conversations about natural family planning. Until then, love responsibly.